Um, Welcome to today's presentation on determinants of mortality among tuberculosis patients at a tertiary hospital in Zambia between 2018 and 2019. I'm your presenter, Dr. Che Webster, internal medicine at Kitwe Teaching Hospital. So I have nothing to disclose about this study that we did. I'll straight go into the background. As you know, tuberculosis is a major public health disease of concern, and it has been the leading cause of mortality from a single infectious agent in the world. When we look at the statistics from 2018, we find that for Zambia, we had an estimated of 28 per 100,000 population in terms of the mortality for those people without HIV, and it was around 74 per 100,000 population for people living with HIV. So we find that this mortality and morbidity is worse when we look at the sub-Saharan countries, and of course higher in those with HIV and those with chronic conditions like hypertension, diabetes, cancers, and the like. So what we did was that in 2018, we conducted a study at Kitwe Teaching Hospital by Chanda et al., where it showed that the mortality from TB accounted for about 21% of all mortalities. And it was the leading cause of mortality among adult patients admitted at our hospital. So this high morbidity and mortality prompted us to undertake a mortality audit so that we understand some of the determinants of mortality among admitted patients with TB at a local hospital setup in Zambia. And I hope this can be generalized to most of the tertiary hospitals across the country. So the method of our study was an audit of mortality files attributed to TB. Also, we did a file review of patients that had TB and died between June 2018 and June 2019. So it was a 12-month period using a standardized data collection form. Then the patients' data that were gotten were extracted and recorded, and then they were analyzed using the SPSS version 9 statistical software. Some of the results that we got were that over 50, that number presenting 67.6% of the studied populations were dominantly male, with a mean age of around 39.2 plus or minus 11.6. So we find that more than 70% of the population were younger than 50 years of age, okay? And over 80% had HIV, with more than 80% residing in high-density residential area. At the time of the presentation, most of the common symptoms that this patient presented with were, of course, productive cough, which stood at 41.9%, and fever, 40.5%. As we know, these are the constitutional symptoms that are present in those people who are presenting with HIV and TB. And these are some of the findings that we had. Also, when we look further, we find that there were some parameters which were statistically significant with a p-value of 0.01. These were HIV positive male patients who had a very high pulse rate, okay, at the time of presentation. And some of them had a deranged mean arterial pressure with a p-value of 0.02. So this is just illustrating further what I'm just talking. When we compared them up on admission and before death, you find that those were female who are HIV positive females, it was statistically significant. And also for the pulse rate, when you compare it on admission and before death, the male were HIV positive at the p-value of 0.01. Further, we analyzed the results, and we found that those who had HIV, who were HIV positive, 6.8% of them, the HIV positive males, had a white cell count of more than 11, and 20.3 had hemoglobin less than 11.1, with a mean CV less than 80 at 21.6 and MCV more than 96 at 4.1. So this is quite interesting, because we know that obviously TB can cause bone marrow suppression if it's disseminated form. But also we see that there may be other concomitant condition that is going with this, to see that the MCV is above 96. So we see that there is also a macrocytic picture with this result. The other finding that we found was that there obviously a mouse organ involvement with hypopinemia in 12.2% of the patients, and 10.8% had deranged renal function, and 12.2% had deranged liver enzymes. As we know, the TB drugs has to be excreted has to be metabolized through the liver and also excreted through the kidneys. So if you see that there is this derangement, then we have something to worry about. So with those findings, we came to a conclusion that at our tertiary hospital, you have a chance of higher mortality if you're a male patient presenting younger than 50 years of age, and also being HIV positive, and of course coming from a high density residential area and presenting with unstable hemodynamics like the lower mean arterial pressure, higher pulse rates, and of course, if you present with anemia. So these are some of the determinants that we found in our study. Looking ahead, we are saying that I think there has been a lot of programs that have been focused at mitigating some of these factors. But I think when you look at the younger population, young to middle-aged men, this is a population which is very active, and you find that most of the time they are missed, or they are not. They are usually very what can I say? They are usually a very active group. So you find that following them up with treatment and everything, they have a higher chance of not taking their medication. And that's why we find that maybe these are some of the factors. So if we can find some strategies to look at these young to middle-aged men, we might be preventing a lot of people from dying from TB. Our follow-up recommendation is that maybe we should do a multi-center prospective study so that we look at some of the parameters for the patient that died from tuberculosis be conducted to ascertain the predictors of mortality and whether the malignancies are a contributing factor to higher mortality among patients admitted with TB and HIV. Now, with this, I thank you.